with the GIT section of first aid, and the first topic we look at is the tongue development. In order to understand the tongue development, we need to understand the pharyngeal arches. Now you can see that we have these the first arch, the third arch, the fourth arch, and the occipital somites. Now the first, third, and fourth arch take part in developing the parts of the tongue. It is important to see that, can you see these colors? So the first arch is represented by green, the second pharyngeal arch is represented by the blue color, the orange one is your third pharyngeal arch, and the fourth yellow one is your fourth pharyngeal arch. So you can see which color is here but not here. That's basically blue. And that's your second pharyngeal arch because it does not take, it regresses, it does not take part in the actual development of the tongue. So the first arch, can you see that these two are the lingual swellings? We call them the lingual swellings, right? The first arch creates lingual swellings, and this small midline area called the tuberculum impart. The tuberculum impart. And then the third pharyngeal arch takes part in forming the hypobranchial eminence. This hypobranchial eminence you can see here. This third thing, this small foramen, this small hole is called the foramen cecum. You can see that here. It's also present here. Now this was your hypobranchial eminence, which was formed, it's a large dorsal part which was formed by the third arch. You can see the orange is the third pharyngeal arch. Then we have the yellow area. It's also the posterior most area. This is the hypobranchial eminence. This is a small dorsal part. You can see this is a small dorsal part, so this creates a small posterior part. This basically creates the posterior most part of the tongue and the epiglottis. So the fourth arch creates the most posterior part of the tongue and the epiglottis. And this orange part is the posterior 1/3 of the tongue. So the third pharyngeal arch, the hypobranchial eminence, this hypobranchial eminence creates the posterior 1/3 of the tongue, and the anterior 2/3 of the tongue is created by the first arch. So this first arch, the two lingual swellings, the tuberculum impar, go on to make the anterior 2/3 of the tongue, right? That's important to understand. And the muscles of the tongue come from the occipital myotomes. All the muscles of the tongue come from the occipital myotomes. So let's look at here. The first pharyngeal arch forms the anterior 2/3 of the tongue. The third and fourth pharyngeal arches form posterior 1/3 of the tongue. And then let's look at the innervation. For the innervation, you should know that the tongue has three different types of innervation. First is the general sensation, which includes touch, pain, and temperature. That's just general sensation. Touch, pain, and temperature. The second is the taste, which includes special sensations. And third is the motor. Motor innervation includes movement of tongue muscles. So these come from different cranial nerves because the tongue develops from multiple pharyngeal arches. So why do you have three different sensations? Because the tongue is developing from multiple pharyngeal arches, so they come from different cranial nerves. Now we talk about the anterior 2/3 of the tongue, the oral part. The general sensation comes from cranial nerve 5-3. Okay, so I'll show you this cranial nerve 5-3, the lingual nerve, which is the cranial nerve 5-3. It basically, the cranial nerve 5-3 is your lingual nerve, and this supplies the general sensation of the tongue, and it comes from the first pharyngeal arch. Okay, so the lingual nerve, cranial nerve 5-3 comes from so basically the lingual nerve is a branch of the trigeminal nerve, which is the cranial nerve 5. The lingual nerve basically provides general sensation like touch, pain, and temperature to the anterior 2/3 of the tongue, also to the floor of the mouth and the lingual gums, also serving as a conduit for taste when it comes to facial nerve, cranial nerve 7, and some autonomic fibers for salivary glands. But what it's important for now is that the lingual nerve is a branch of the trigeminal nerve, and it provides general sensation like touch, pain, and temperature to the anterior 2/3 of the tongue. Then we also have we have taste, right? So the taste of the anterior two-third comes from the chorda tympani nerve. So the chorda tympani nerve, the cranial nerve 7, has a branch, the chorda tympani. The cranial nerve 7 is a facial nerve. So it has a branch called chorda tympani. This joins the lingual nerve, and basically the chorda tympani gives, this has cell bodies in the genicular ganglion, and using the central pathway, using the nucleus tractus solitarius, it basically conveys the taste sensation. So the lingual nerve carries sensation and the chorda tympani nerve carries tastes, but they travel together. Now the uh, posterior two-thirds of the tongue, the sorry, posterior one-third of the tongue is a little different. So when we talk about the posterior one-third of the tongue, we're going to talk about the cranial nerve 9, which is the glossopharyngeal nerve. So the posterior one-third is supplied by the glossopharyngeal nerve, which is the cranial nerve 9. This comes from the third pharyngeal arch, and if you remember, our third pharyngeal arch was part of creating the posterior one-third of the tongue. This is the only part where one nerve does both sensation. So glossopharyngeal is responsible for tasting and general sensation. Okay. Now we have the extremely posterior part of the tongue, which is the epiglottis area. This is supplied by the vagus nerve. Okay. So the cranial nerve 10, the vagus nerve via internal laryngeal nerve. This internal laryngeal nerve, the vagus nerve gives you the internal laryngeal nerve, and this comes from the fourth pharyngeal arch, because the fourth pharyngeal arch was responsible for creating this most posterior part of the epiglottis. So this is very important. It shows up a lot in the exams. When we talk about the motor innervation, there's just one exception. So all intrinsic and extrinsic muscles of the tongue, all of them are supplied by the hypoglossal nerve, and that's your cranial nerve 12. So all the muscles of the tongue are supplied by the hypoglossal nerve, and that's your cranial nerve 12. Just one exception, and that exception is palatoglossus. So palatoglossus is the only muscle that's innervated by the cranial nerve 10, which is your vagus nerve, and this is supplied through the pharyngeal plexus. So through a pharyngeal plexus, the vagus nerve innervates the palatoglossus. Otherwise, all the muscles, the intrinsic and extrinsic, all the tongue muscles are supplied by the cranial nerve 12, which is basically the hypoglossal nerve. Now, this palatoglossus, which is innervated by the vagus nerve 10, and it's an exception because it's not innervated by the hypoglossal nerve like all the other muscles of the tongue. So this muscle elevates the posterior tongue during swallowing. So that's your innervation of the tongue. So you can remember, so for example, if you have a loss of taste in the anterior two-third of the tongue, but sensation is intact, you know which nerve it is. So loss of taste in the anterior two-third of the tongue, but the sensation is intact. So that's your chorda tympani nerve. Loss of gag reflex, that's a sensory problem. If you lose the gag reflex, that's a cranial nerve 9 problem, right? The glossopharyngeal. Now, if the tongue deviates towards the lesion, whenever your tongue deviates towards the lesion, that's a cranial nerve 12 problem. Why? Because your all the muscles of the tongue are supplied by the hypoglossal nerve. So cranial nerve 10 problem, and that's a lower motor neuron lesion. You'll understand this later on. If there's a difficulty swallowing, posterior tongue. There's a difficulty swallowing in the posterior tongue, then you have a cranial nerve 10 problem or a palatoglossus problem. So I hope you understand that. We'll read what's here. So sensation via the cranial nerve 5-3, taste via cranial nerve 12. What is this talking about basically? So the first pharyngeal arch forms the anterior two-third of the tongue, and it's saying that the sensation is provided by the cranial nerve 5-3, which is your lingual nerve, which is coming from the trigeminal nerve, which is your cranial nerve 5, and taste by cranial nerve 12. This is your chorda tympani, not 12, sorry, 7. This is your chorda tympani nerve, which is coming from the facial nerve. Third and fourth pharyngeal arches come from the posterior one-third of the tongue. They form the posterior one-third of the tongue. Sensation and taste mainly via cranial nerve 9. What was our cranial nerve 9? It was our glossopharyngeal nerve, right? And extremely posterior via cranial nerve 10. So the extreme posterior part is supplied by the vagus nerve 10. Then motor innervation is via cranial nerve 12 to hyoglossus, retracts and depresses tongue. Genioglossus protrudes tongue. Styloglossus draws sides of the tongue upward to create a tuft for swallowing. So all the motor innervation to all these muscles of the tongue is innervated by the cranial nerve 12, which is your hypoglossal nerve. Motor innervation to palatoglossus comes through cranial nerve 10. So cranial nerve 10 innervates palatoglossus. All others are coming from hypoglossal nerve. All the other muscles are innervated by the hypoglossal nerve. And which nucleus was we were using? The nucleus tractus solitarius for cranial nerve 12, 9, and 10. Okay. Now the normal gastrointestinal embryology. Remember now we have something called as the foregut, midgut, and hindgut, right? What is basically the foregut? The foregut is if you kind of like divide. Um, okay, this is important, so I need to show this to you. So the foregut is all the part that starts from the esophagus to the proximal duodenum up to the major duodenal papilla or ampulla area supplied by the celiac trunk. Now there's something there are two papillas or openings in the duodenum in the mid level of the duodenum. The duodenum is divided into four major sections, and we will see that the second part of the duodenum has these two major these two openings. We call one of them the major duodenal papilla or the ampulla area. You'll see that later on, but just remember for now, what is the foregut? The foregut is the area from that start from the esophagus up to the major duodenal papilla. Now, this area is supplied by the celiac trunk because embryologically the foregut is supplied by the celiac trunk. So later on, when you'll see the development of all these embryological parts, you'll see that the celiac trunk is supplying the foregut. Now you have something called the midgut. The midgut starts from after, because the first part foregut was till the duodenal papilla. So after this, the distal duodenum, all the way up to the proximal two-third of the transverse colon. Now the colon is also has four parts that we'll see later on: the proximal colon, the transverse colon, the distal colon, the sigmoidal colon, and so on. So we know that the distal duodenum till the proximal two-third of the transverse colon is supplied by the superior mesenteric artery. So from here you can see that the duodenum will have a dual supply. It will have the first part of it being supplied by the celiac trunk, and it will have the second half part of it being supplied by the superior mesenteric artery. Then you have something called the hindgut. The hindgut is basically the distal one-third of the transverse colon. The distal one-third of the transverse colon is the hindgut, and it is the distal one-third of the transverse colon is the hindgut. It starts off from there and continues up until the upper anal canal. Sorry, I got a little confused. This is supplied by the inferior mesenteric artery. So are we clear here? The foregut is supplied by the celiac trunk, the midgut is supplied by the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. Okay, so aorta has basically three unpaired trunk. The celiac trunk is for the foregut, superior mesenteric arteries for the midgut. We'll see how the rotation axis moves, and the inferior mesenteric arteries for the hindgut. Now, look at here. The foregut is esophagus to duodenum at level of pancreatic duct and common bile duct insertion into the ampulla of Vater. So that area where I was talking about, where the foregut basically ends, is where the pancreatic duct and common bile duct insert themselves into this area. This is called the ampulla of Vater. And by the way, if a stone gets lodged in the ampulla of Vater, what we're going to have? You're going to have increased of pancreatic juice, and you're going to have bile obstruction. You're going to see that later on. So at the 4th to 6th week of development, the stomach rotates 90 degrees clockwise. You should know that, and I'll show it to you. So can you see, this is the dorsal mesentery and this is the ventral mesentery, and how the stomach is rotating basically at a 90 degrees axis. When it goes all the way around the 90 degrees axis, you have the ventral here and the dorsal on the opposite side. How is this even possible? It's possible because the stomach rotated at a 90-degree angle, right? So the stomach basically rotates at a 90-degree angle, and that's how you have this left greater curvature because of the ventral dorsal axis rotation, right? So what did we say? We saw that the stomach rotated at a 90-degree angle clockwise at the 4 to 6 week of development. Now this left vagus becomes anteriorly positioned and right vagus becomes posteriorly positioned, right? So if something is going around 90 degrees clockwise, your left vagus will go around posteriorly, right? Sorry. If it's going around, if the stomach is rotating around 90-degree clockwise, the left thing is going to come anteriorly, yes, and the right thing is going to go posteriorly. Just try to imagine the hands of a clock rotating. Right now, imagine the clock in your hands and the center is your palm. So, imagine if that needle goes 90 degrees clockwise, so whatever was already on the left, so for example, if on the left was 3 p.m., so if I'm going to rotate it 90 degrees, 3 p.m. is going to become 6 p.m., right? So your left vagus was left placed like 3 p.m. and now it's going to become anteriorly positioned, so it's going to become 6 p.m. and that's going to be anteriorly positioned. And the right vagus was probably 9 p.m. and 9 p.m. is now going to go at the back and become 12 p.m. midnight. I really hope I can make you guys imagine that. So it's very easy, you know. Now, the midgut. The midgut starts from the lower duodenum to proximal two-third of the transverse colon. At the sixth week of development, there's a physiological herniation of the midgut through the umbilical ring. So there's a physiological herniation of midgut through the umbilical ring, and the yolk sac and midgut are connected by the vitelline omphallomesenteric duct. Now, first, let's see what does the midgut include. The midgut basically includes part of the distal duodenum. So, after the stomach, here part of the distal duodenum. Then you have the jejunum and ileum, and you have the cecum and ascending colon, and then proximal two-third of the transverse colon. All of this is supplied by the superior mesenteric artery. Now, what are we seeing here? Basically, you have different movements. At the beginning of the sixth week, the midgut elongates to form a ventral U-shaped midgut intestinal loop. So you kind of form a loop here, right, at the herniation area. Midgut loop communicates with the yolk sac by vitelline duct or yolk sac. So, using like this vitelline duct or yolk sac, this midgut communicates to the umbilicus. As a result of rapidly growing liver, kidneys, and gut, the abdominal cavity is temporarily too small to contain the developing, rapidly growing intestinal loop. So, since in the baby you are getting the liver is growing, the kidneys are growing, the gut is growing, your abdominal cavity is growing, so it's not possible to keep all this intestinal loop inside the body. So, the midgut loop projects into this umbilical cord, and this is called physiological umbilical herniation. So all of this intestine basically herniates because you don't have enough space inside the baby to keep this up, right? Now what happens is that, and by the way, all this midgut area is supplied by which artery? Superior mesenteric artery. Now the midgut grows faster than the abdominal cavity and herniates into the umbilical cord. It's connected to the yolk sac by the vitelline or omphallomesenteric duct, right? I will try to show it to you if it's here. Yeah, here you can see it's connected to the yolk sac through the vitelline, or also called the omphallomesenteric duct. This is normal, this is not a defect. Now what happens is at week 10 there's a okay, during herniation there's a 90-degree rotation, right? So during herniation, there's a normal 90-degree counterclockwise rotation, and this is normal. So there's a 90-degree and counterclockwise, like anti-clockwise rotation, and this is during herniation. But later on, when it's returning to the abdomen, so you can see this purple part is above and this colorful part is below. Now another rotation will take place when returning to the abdomen. When it returns to the abdomen, it goes around post herniation, it takes another 180-degree turn. So that purple part, can you see this purple part here? Now this purple part is going to go around another 180-degree and come here, right in front. So there's a total 270-degree rotation, right? So the small, what happens in the end? In the end, you have this small intestine which is present centrally, and then you can see like what was your small intestine. This was the stomach, so all this colored part was your small intestine, right? So all of your colored part is present centrally, and the colon frames the small intestine. So all this colon is somehow framing the small intestine, is going around it, right? And the cecum descends to the right lower quadrant. So that happens. Now, a malrotation here will cause a valvulus, and a persistent vitelline duct here, one that does not regress, will cause a Meckel's diverticulum, and you basically have a connection from the intestine to the umbilicus, right? Now, um, I hope that's clear. Let's look at what is written here. During the 10th week of development, it returns to abdominal cavity, rotating around superior mesenteric artery to 70 degrees counterclockwise, 90 degrees before 10th week, remaining 180 degrees in 10th week when contents retract back into abdominal cavity. And here, a persistent white line duct will lead to a Meckel's diverticulum. The hindgut is easy. The hindgut includes the distal one third of the transverse colon, this orange part, and it's supplied by the inferior mesenteric artery. It has a descending colon, a sigmoid colon, a rectum, and the upper anal canal above the pectinate line. The blood supply is inferior mesenteric artery, and remember that above the pectinate line is your endoderm creating the GIT. But below the pectinate line, the ectoderm creates your GIT, the rest of the area, anal area. And this is important for pain and like cancer cases and lymph cases. We'll see that later on. Okay, so I think that's enough for this image. I'm going to stop it here. This was a very high yield, intense kind of a session. So that's why I think it's 20 minutes. The video is 20 minutes. Let's move on.